Hi there, my highly valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high impact pharmacotherapy services in your line of duty. So I'd like to humbly urge you to sit back and spare me part of your precious time to share some tips that you may find useful in your line of duty. So question 1 reads, your clinical team is managing a female patient with no significant past medical history. Her chief complaint when she presents to the clinic is she feels tired, doesn't have, in her words, enough energy most of the time. She's unable to tolerate cold environments. Her skin has been unusually dry. She is concerned about recent weight gain. She's lost 10 to 15 pounds to be precise, despite eating right. She asks your team if she could be having a problem with her thyroid. The team orders a thyroid function test, and the results are as follows. The TSH is 68 million units per liter. The free T4 is 0.5 nanograms per deciliter. Now, basing on the lab results, which of the statements below is correct? Is it a case of hyperthyroidism and you need to initiate levothyroxine? Or is it hypothyroidism, initiate levothyroxine? Or is it hyperthyroidism, initiate methimazole? Or is it hypothyroidism and you recommend initiation of methimazole? I'll give you 10 seconds to choose the correct answer. So the best option, in my opinion, would be B. Now, some common signs and symptoms of hypothyroidism include fatigue, cold, intolerance, hair loss, brittle hair, weight gain, dry skin, constipation, and muscular aches. And our patient here appears to be experiencing some of them. Now, her TSH, in my opinion, is elevated and her free T4 is low, suggesting hypothyroidism. Now, levothyroxine is a synthetic T4 and it's the drug of choice in hypothyroidism. The other one, which is methimazole, is a drug of choice in hyperthyroidism, not hypothyroidism. So all those many words would make me settle for alternative B as the correct answer. Let's move to the next question, please. Patient T.M.C, a 68-year-old female, presents to the hospital with a past medical history of type 2 diabetes mellitus, which was diagnosed 10 years ago, an MI which was diagnosed at the age of 64. Her current list of medications include Metformin ER. She takes 1,000 milligrams twice daily after breakfast and after dinner. She also takes linagliptin at a dose of 5 milligrams once daily. Some of the vitals and pertinent lab results include a systolic blood pressure of 130, diastolic 676, a heart rate of 70, an A1C of 7%, an EGFR of 65, LDL cholesterol of 80, HDL of 38, and a TG of 140. My question to you is, which of the therapeutic changes listed below would you recommend for patient TMC's current regimen? Would you opt to continue the current therapy? Would you discontinue linagliptin and initiate liraglutide? Would you discontinue linagliptin and initiate dapagliflozin? Or would you initiate exenatide? I'll give you 10 seconds to choose the correct answer. B is the correct answer. I would discontinue linagliptin and initiate liraglutide. Now discontinuing linagliptin and starting liraglutide would be the best option for our patient TMC, in my opinion. Now the DPP-4 inhibitors and the GLP-1 agonists should be avoided in combination. Now, TMC has a history of myocardial infarction, therefore, liraglutide is appropriate for secondary cardiovascular benefits, even though he is controlled on the metformin DPP-4 inhibitor combination. Now, dapagliflozin would be appropriate for this patient, but it doesn't offer any cardiovascular benefits regarding reduction of any CV events or death, although it offers a reduction in hospitalizations for heart failure. Option D, which is exenatide, doesn't have any proven cardiovascular disease benefits or labeled indications, so liraglutide or semaglutide injections should be chosen for this particular scenario. Now, recommendation for type 2 diabetes mellitus patients is to add therapies with cardiovascular benefits and CKD benefits, regardless of the A1C, and that consideration should be made when you are altering therapy. You should swap with a drug that will benefit, will lower the risks in heart failure patients and in chronic kidney disease patients. Now, for heart failure or chronic kidney disease patients, we can consider canagliflozin, dapagliflozin, or empagliflozin. From literature, we know that canagliflozin has CKD indication with albuminuria, dapagliflozin has heart failure indication, and all the three have positive outcome data in both heart failure patients and chronic kidney disease patients. It's widely written in literature, just for your information. So I would settle for B. Let's move to the next question. It reads, which of the statements below is true regarding the use of levothyroxine for the treatment of hypothyroidism in a female patient with a gestation period of 4 weeks? The lady is 28 days pregnant. Is it true that the dose will likely need to be increased by no more than 10%? Or is it true that the dose may need to be increased by up to 40% during the first few months of pregnancy? Or is it true that the dose will need to be decreased by 25%? Or is it true that the dose should remain unchanged throughout the pregnancy? I'll give you 10 seconds to choose the correct answer. Correct answer is B. Now, during the first few months of pregnancy, the free and bound availability of T4 is reduced, normally due to an elevation in the production of the thyroid binding globulin from the elevated estrogen levels seen in pregnancy. Now, this increase in the binding protein binds up T4 in greater quantities, making T4 less freely available for the pregnant mother and for the baby in utero to utilize. Remember, there are two beings here depending on the T4. Now, in order to overcome this increasing binding, more synthetic T4 must be provided to the hypothyroid pregnant patient who can't make sufficient quantities to overcome this physiologic effect. The dose increase in the first 2 months can be as high as 45%. Now, appropriate increase in the dose of levothyroxine early in pregnancy has been shown to reduce the risks of miscarriage, of preeclampsia, of stillbirths, and of lower IQs in the babies who survive. Those are just by the ways, and those are facts that emphasize the need to rationalize or optimize the levothyroxine dose in pregnancy. Let's move to the next slide, please. SDF, a 47-year-old female, is newly diagnosed with type 2 diabetes mellitus. Your clinical team is evaluating her for pharmacologic treatment. Her vitals and pertinent lab results include a systolic blood pressure of 129, diastolic 73. She has a BMI of 33. She's obese. A1C of 8.7, an EGFR of above 60. The kidneys are not doing so badly. The UACR of 18 milligrams per gram. So my question to you is, which of the regimens below would be the most ideal to initiate SDF therapy with? Would you settle for Metformin and lifestyle changes? Or would you administer Metformin alone? Or would you co-administer Metformin and dulaglutide and encourage lifestyle changes? Or would you co-administer Metformin and pioglitazone? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for Metformin, dulaglutide, and encourage lifestyle changes. Now, this combination provides early combination therapy that has been shown to be potentially able to reduce the decline in glycemic control while also promoting weight loss. Remember, this patient is obese with a BMI of 33 and would therefore benefit from such a combination. Now, other combination studies such as the Verify VERIFY trial also demonstrated a reduction in the decline of glycemic control with the initial Metformin and vildagliptin treatment compared to Metformin or sequential use of Metformin and vildagliptin, which is how most providers usually opt to initiate their therapy. Now, initial combination therapy should be started if the A1C exceeds the 1.5% mark, above the target, in order to slow the decline in this glycemic control. Now, answer D, pioglitazone, in my opinion, would be a less desirable option since SDF is an obese patient and pioglitazone is notorious for promoting weight gain. So the BMI would rise even higher. I would not opt for D. Now, dulaglutide, which is marketed as Trulicity, is a GLP-1 receptor agonist that doesn't require titration from the 0.7 milligram weekly to 1.5 milligram weekly. However, for patients who are GLP-1 naive, they may experience effects if we started high at a level of 1.5 milligrams weekly. That's just for your information. Let's move to the next question, please. It reads, which of the medications listed below can inhibit the peripheral conversion of T4 to the more potent form of the thyroid hormone T3 in patients suffering from thyroid storm? Would it be methimazole, propranolol, atenolol, or SSKI? I'll give you 10 seconds to choose the correct answer. SSKI, by the way, is an abbreviation for supersaturated potassium iodine. Personally, I would settle for propranolol, and it's the only drug from the above list that has been shown to reduce peripheral conversion of T4 to T3. It is sometimes used in the acute management of thyroid storm, what we call thyrotoxicosis. Now, methimazole, alternative A, is a thionamide that inhibits the synthesis of thyroid hormone by blocking the iodination of thyroglobulin inside the thyroid gland itself, and not in the periphery at all. So that would be a wrong answer. Now, the SSKI impairs both thyroid hormone production within the thyroid gland and vascularity of the thyroid gland, but has nothing whatsoever to do with the T4 conversion to T3 in the periphery. Propranolol, on the other hand, is also used for migraine prophylaxis, prevention of bleeding from esophageal varices in patients with cirrhosis, for example. So it's a useful drug in endocrinology. Just as a by the way, let's move to the next question, which reads, your clinical team is treating a female patient with hypothyroidism. So my question to you is, which of the statements below best describes the appropriate use of levothyroxine? Should you administer it without regard to meals since food does not affect its absorption? Or is it true that it shouldn't be co-administered with calcium or iron containing substances? Or is it true that the dose reduction will be needed during pregnancy? Or is it true that it can be taken when necessary, that is PRN, when symptoms of hypothyroidism worsen? I'll give you 10 seconds to choose the correct answer. In my opinion, B is the correct answer. It should not be co-administered with polyvalent iron-containing substances. Now, levothyroxine is best absorbed when taken on an empty stomach, and we should encourage patients to take it at the same time every day. Now, that makes alternative A wrong, and I would like to emphasize the fact that it shouldn't be co-administered within 2 to 4 hours of any di or trivalent cation containing substances. Those antacids, for example, that contain aluminium, calcium, magnesium, or hematinics that have iron, for example, because all those polyvalent and divalent cations have the ability to bind levothyroxine in the GIT, and that prevents its absorption. So you'd end up with a very low bioavailability, and therapy would fail. Now, levothyroxine has never been used on a PRN basis, like is suggested in alternative D. Hypothyroidism is a chronic disease which requires daily drug administration, not when necessary doses. PRN doses would not work for this particular condition. Now, I would also like to add that levothyroxine doses normally should be increased by an average of 48% during the first 8 weeks of pregnancy, as this will reduce risks of low IQ among the kids that are born, risks of miscarriage, or risks of preterm labor. Those are just facts for your information that justify why C would be wrong. Let's move to the next question, please. It reads, J or J, a 64-year-old white female patient, presents to the endocrinology clinic with unexplained weight loss. She's lost about 10 pounds to be specific in the past 1 month. So she complains of feeling hot most of the time, in her own words, with excessive sweating. She also says in her own words she's tired of feeling more irritable and anxious for no good reason. Some of the pertinent physical findings include warm, moist skin, exophthalmos, and tachycardia. Now, based on the provided information, which of the statements below is the most appropriate concerning J or J's condition? Is it Hashimoto's disease and we need to initiate levothyroxine? Is it Graves' disease and we need to start the Methimazole? Is it Graves' disease and we need to initiate levothyroxine? Or is it Hashimoto's disease and we need to initiate Methimazole? I'll give you 10 seconds to choose the correct answer. In my opinion, we are dealing with Graves' disease, and the best choice would be initiation of Methimazole. Graves' disease is the most common cause of thyrotoxicosis in non-iodine deficient, the deficiency regions. It is an autoimmune disease caused by the thyroid stimulating hormone receptor antibodies. Now, these antibodies stimulate the TSH receptor, leading to overproduction of thyroid hormone. Now, symptoms of thyrotoxicosis may include weight loss, heat intolerance. They may have warm, moist skins. They may experience anxiety, nervousness, tremor, palpitations, and even clinical signs like tachycardia, atrial fibrillation, goiter, and exophthalmos may be present. Now, lab findings in Graves' disease include a decreased TSH level because the pituitary gland isn't producing TSH, as the TSH receptor antibodies are stimulating the thyroid instead. There can also be an increase in total or free T3 and T4 levels, which are producing a negative feedback to the hypothalamus and the pituitary, resulting in decreased endogenous TSH production. Now, the treatment of Graves' disease includes antithyroid medication such as propylthiouracil or Methimazole. We can also do thyroidectomy, or we can use radioactive iodine ablation. All the three can work. Now, Hashimoto's disease is a common cause of hypothyroidism. the above symptoms are not consistent with hypothyroidism. Remember, in hypothyroidism, the patient would complain of fatigue, cold intolerance, hair loss, brittle hair. There could be weight gain, there could be dry skin, there could be constipation and muscular ache. Now, the appropriate treatment in such a case of hypothyroidism would be synthetic T4, levothyroxine or synthroid to be specific. So that's just to explain why I think this is Graves' disease and I would opt for Methimazole. Let's move to the next question, please. Which of the warnings below concerning SGLT2 inhibitors isn't applicable or relevant? Is it a warning concerning necrotizing fasciitis, DKA, pancreatitis, or hypotension? I'll give you 10 seconds to choose the correct answer. Pancreatitis it is. Now, pancreatitis is a possible adverse outcome of the use of DPP4 inhibitors or GLP-1 agonists, not SGLT2 inhibitors. The SGLT2 inhibitors can cause necrotizing fasciitis of the perineum, and patients should be advised by the service provider to notify their providers of any genital or perianal pain, any fever, any edema, any erythema, or tenderness in that region. Now, these SGLT2 inhibitors can also cause euglycemic diabetic ketoacidosis in type 2 diabetes and type 1 diabetes. We should consider factors that may predispose patients to DKA, which include decreases in insulin doses, pancreatic insulin deficiency, acute illness, caloric restriction for one reason or another, alcohol abuse, or even surgery. Now, discontinuing SGLT2 inhibitors at least 3 days prior to surgery is now recommended if you read most forms of literature to avoid complications from occurring. Now, patients with nausea and vomiting, abdominal pain, malaise, or shortness of breath should be evaluated for DKA. Now, due to intravascular volume depletion, remember they lead to peeing a lot of glucose in urine, and with the glucose goes a lot of water. So the patients may end up over-diuresing and end up volume depleted when they use the SGLT2 inhibitors. And this can cause hypotension when they lose those huge volumes of water. Now, in patients with an eGFR of less than 60, or in the elderly patients who are treated for hypotension, or those with low or normal blood pressure, this effect I've just described may be more pronounced. Now, the SGLT2 inhibitors carry several warnings, including bone fracture, necrotizing fasciitis, lower limb amputation, hypotension, diabetic ketoacidosis, genital mycotic infections, acute kidney injury, and urinary tract infections. Providers should be familiar with these warnings, which are written in most literature inserts, and select appropriate patients for SGLT2 inhibitor therapy. Otherwise, if patients ended up with these side effects, there would be issues with adherence. Some of them would stop their treatment. Now, bone fractures haven't been associated with empagliflozin or L2-glyphosine use. So those would be very handy in patients at risk of experiencing bone fractures. Now, risk factors for lower limb amputation are or a history of amputations or peripheral vascular disease or neuropathy, or a history of feet ulcers are things we may need to look out for. Yeah, any patient who had those risk factors is not a good candidate for the SGLT2 inhibitor therapy. I would just like to underscore the fact that the genital mycotic infections with SGLT2 inhibitors can be managed with fluconazole. And when you use the fluconazole, they, in most cases, they are limited to one occurrence. Now, there are those exceptions where multiple infections may occur. Now, if this happens, then we should consider other therapies, because we need to appreciate the fact that resistance to fluconazole is pretty high in the general population. That's just a by the way. Let's move to the next question, please. JWW, a 78-year-old male patient, presents to the endocrinology clinic at your hospital for follow-up. He has a past medical history of type 2 diabetes mellitus, and he informs the team his morning fasting blood glucose readings are between 78 and 110 milligrams per deciliter. Now, he reported one FBG reading of 53 milligrams per deciliter in the morning and says he felt just fine and couldn't tell the difference. His A1C is 7.5% and he's only on insulin therapy. So my question to you is, which of the statements below would be correct for the management of hyperglycemia in this patient? Is it glucagon is the preferred treatment for unconscious patients with blood glucose levels below 70 milligrams per deciliter, or is it after treatment of hypoglycemia? Once the self-monitored blood glucose SMBG returns to normal, the individual should consume a meal or a snack to prevent recurrence of hypoglycemia, or is it 30 minutes after treatment of hypoglycemia with 20 grams of glucose? If the SMBG reading shows continued hypoglycemia, treatment should be repeated. Or is it true that the ADA recommends a preprandial glycemic target of 70 to 130 milligrams per deciliter to prevent hypoglycemia? I'll give you 10 seconds to choose the correct answer. In my opinion, B is the correct answer. Now, once the hypoglycemic episode is treated and the SMBG is above 70 milligrams per deciliter, the individual should have a meal or a snack to prevent the recurrence of hypoglycemia. Now, glucose is the preferred treatment for a conscious individual with a blood glucose less than 70 milligrams per deciliter. Glucagon, on the other hand, is indicated for treatment of hypoglycemia in those who are unable or unwilling to consume carbohydrates orally. Now, 15 minutes after treatment of hypoglycemia, SMBG should be repeated to check if the blood glucose readings are within normal levels. Now, in the 2015 ADA changed its preprandial glycemic target from 70 to 110 and moved it to a range of 80 to 110 milligrams per deciliter to decrease over treatment and to provide a safety margin to avoid many episodes of hypoglycemia. Now, hypoglycemic unawareness, like in the case of this patient, or one or more episodes of severe hypoglycemia with an altered mental status or physical status requiring assistance, should trigger re-evaluation of a treatment regimen. Those are just, by the way, to help you manage these patients better. Let's move to the next slide. And our question reads, EPK, a 67-year-old white female, was initiated on synthroid levothyroxine. So my question to you is, which of the statements below would be the most accurate counseling point for Madam EPK? Would it be that synthroid can be taken at the same time as all other medications? Or is it true that synthroid should be taken with food? Or would you advise her that synthroid should be taken half an hour before breakfast? Half an hour to 1 hour, before breakfast? Or would you inform her that synthroid should be taken at least 2 hours apart from other medications that are known to interfere? I'll give you 10 seconds to choose the correct answer. So, in my opinion, C would be the correct answer. Synthroid should be taken half to 1 hour before breakfast. Remember, synthroid is used as a replacement or supplementary therapy to hypothyroidism, and it should be taken on an empty stomach, half to 1 hour before breakfast. And it should be taken at least 4 hours apart from other drugs, especially the polyvalent containing medications, which are notoriously known to chelate it and interfere with its absorption. That makes answer C correct. Let's move to the next question. Patient ZZK, a 69-year-old patient, presents to the endocrinology clinic with a past medical history of type 2 diabetes mellitus, peripheral neuropathy, hypertension, dyslipidemia, heart failure, stage C to be specific, or New York Heart Association class 3. The patient also suffers from chronic kidney disease and is obese. The patient currently takes 1,000 milligrams of metformin after breakfast and after dinner, Trajenta at a dose of 5 milligrams once daily to regulate the sugars, lisinopril at a dose of 40 milligrams once daily, metoprolol succinate at a dose of 100 milligrams once a day, alongside 40 milligrams of furosemide once daily, and 20 milligrams of rosuvastatin at bedtime, high intensity statin therapy. And because of the neuropathy, the patient also takes 300 milligrams of gabapentin orally thrice a day. Some of the vitals and the pertinent lab results include a systolic blood pressure of 130 and a diastolic blood pressure of 86 with a heart rate of 73. The BMI is 35, pretty high. The potassium levels are 4.5. The serum creatinine is 1.3. The EGFR is 59. The UACR is 56 milligrams per gram. The A1C is 7.3. The left ventricular ejection fraction is 40. And the LDL cholesterol is 85. So my question to you is, which of the recommendations below would best suit ZKK's type 2 diabetes mellitus management? Would you add Invokana, which is called canagliflozin, at a dose of 100 milligrams once daily to the therapy? Or would you continue status quo? Or would you discontinue Trajenta, the linagliptin, and start Farxiga, which is dapagliflozin, at a dose of 10 milligrams once a day? Or would you discontinue Metformin and start Ozempic, which is semaglutide, at a dose of 0.2 milligrams subcutaneously weekly, and titrate as tolerated? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for discontinuing linagliptin, and I would initiate dapagliflozin at a dose of 10 milligrams once daily. Now, we realize that ZZK is an elderly patient. The age, if I remember well, was 69, to be specific. And this patient has significant comorbidities, so he would be considered at goal A1C. We don't want to be very strict with the glycemic control. So utilizing less strict goals would help us avoid complications from additional medications or from adverse effects. Now, standards of practice recommend adding or substituting medications with evidence in cardiovascular disease, heart failure, and or chronic kidney disease patients. Meeting A1C goals with these conditions who are not taking medications to improve outcomes in their disease states. Now, since his A1C is at goal, and dapagliflozin, the Farxiga, would provide a greater A1C lowering than linagliptin, which is Trajenta, it would be reasonable to discontinue Trajenta and add Farxiga to gain the potential reduction in hospitalizations for heart failure, which is an added advantage of Farxiga, as well as the benefits in chronic kidney disease progression and clinical outcomes. Now, this Farxiga may also assist with weight loss that would further improve the patient's other disease states. Remember, we were told the BMI was around 35, if I remember well. So I would also just like to emphasize that continuing the current therapy would not be optimal because the patient is not on any agent that improves heart failure outcomes, while we know that the SGLT2 inhibitors are available and are reasonable in heart failure patients. Now, canagliflozin is associated with potential increase in risk of amputation in patients with risk factors. So, although there is evidence of benefit for heart failure and chronic kidney disease outcomes, another SGLT2 inhibitor, in my opinion, is more desirable than canagliflozin. Now, other SGLT2 inhibitors don't have the same level of data with lower limb amputations as Invokana, which is the canagliflozin. Now, Farxiga doesn't carry this warning either, so it would be a good choice. I would also like to add that ZZK, or his heart failure, appears stable, so Metformin may be continued and may also provide benefit. Now, DPP-4 inhibitors can't be used in combination with GLP-1 agonists. So you cannot add semaglutide, which is Ozempic. Ozempic and other GLP-1 agonists don't have any indication for reduction of heart failure hospitalization, although some of them may reduce CVD risks. So in my opinion, if SLGT2 inhibitors were contraindicated, then the GLP-1 agonists such as dulaglutide, semaglutide, or liraglutide could be recommended for the case of this particular patient we are discussing. So those are just by the ways to justify why I would settle for answer C. So my highly esteemed viewers and listeners, that brings us to the end of part 36 of our Pharmacotherapy MCQ series. If this video helped you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your peers and colleagues. And if you haven't yet done so, I would like to encourage you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come, and I'm very thankful for your support and for your continued collaboration. I appreciate the fact that you made time to view and to listen to this video, and I look forward to interacting with you in part 37 of our Pharmacotherapy MCQ series. Thank you for always being there for me.